So today we're going to be discussing resectable gastric and GEJ cancer. We're going to really be focusing on the adenocarcinoma histologies. So we're not going to go further up the tube into the cervical and thoracic esophagus. We're going to stay lower down, relatively speaking.
Understood.
We really just want to make this a discussion of like the current landscape, where we're at today, and also just thinking about how to translate our modern clinical trials such as Matterhorn into clinical practice. So try to keep it applicable here. And I have an expert who has treated, I don't even know how many patients with gastric cancer in the last, I'm not going to date you.
Well, you can.
5 years, 2 years?
I think I finished my fellowship in 2003, so you can do the math.
I was a little under.
It's more than a little and less than a whole lot.
Okay, nice. So, we're going to start way back in time to what were you doing in 2003 for gastric cancer? We weren't, immunotherapy wasn't around, that's for sure.
True.
We were not in a place where we were doing much even chemotherapy for our patients to cure them.
I agree. It was a wind back in time where we did not have even Herceptin. Toga trial, I think, and that's for recurrent metastatic disease, was 2013 or something. So this would be in the early aughts, I think you say.
Yeah. I think the classic trial in Asia was early 2010.
Yeah.
So 10 years before that, definitely not giving a ton of chemotherapy for our patients with resectable disease.
True.
It was probably just surgery and hope for the best.
Pretty much, yeah. In fact, I remember reading the paper probably when I was a first-year fellow that talked about adjuvant chemoradiotherapy. It's an intergroup trial, I think, for resected gastric and GE junction. I do not believe we did that for esophagus because we tended to give preoperative chemo-RT even back then. But I remember one of my fellows helping me. Speaking of, thank you very much.
That's what we're here for.
All the past.
We're really good at writing notes.
He made me a time chart.
Yeah, see, there you go.
Yeah. So
that's better than I ever did.
But we're not going to say. We'll talk later. But the chart was how you integrate the radiation and the chemoradiation portions of this. I think it might have been even 6 months of adjuvant therapy. So it was like a month of 5FU, then 5 weeks of concurrent, and then another couple of months of, I think it was just 5FU. And tell you what, that was not easy. I remember a patient, and this makes you think about sort of how we're doing quality and quantity math. Well, it's not math, but in our heads. And only in retrospect did I realize that I continued to see this patient for several years with just the most chronic GI cramping and malabsorption and dumping, and he was miserable. But as he used to say to me, well, I'm here telling you this. But I learned to not be a fan of postoperative chemo-RT for resected gastric cancer. But fortunately,
makes sense.
The field developed.
Yeah.